has done 2 presentations for us this week. So please make Loren feel very welcome. She comes up for the final time here in Rusutsu for this year. Loren.
Thank you. All right, hey everyone. So I have the glorious task of wowing you in the last session. And I'm hoping that in the next hour or so, maybe a bit less, I can really give you an idea about where virtual care is going in Australia and give you some great ideas about innovation in the healthcare space. I don't have any declarations other than an apology from Susie, who was presenting this with me. She and her son broke their wrist in the 3 weeks leading up to this conference. So an executive decision was made by their family not to attend, which I think was fairly wise. Anyway, so what is the definition of virtual care? For those of you who live in the virtual world, it's healthcare delivery separated by distance, and it's using communication technologies, be it phone or video. So originally when I started doing virtual care a couple of years ago, the emergency world turned around to me and said, don't be ridiculous, what are you talking about? We can't do virtual care, this sounds like a really dumb idea. But we already do virtual care every single day on the emergency department floor, yeah? So we have urgent cares and GPs phoning us to speak to our emergency physician in charge. When I see a patient and I think, oh, that might need a surgical plastics consult, I take a photo and I send it to the registrar and I say, oh, get back to me with a plan. In retrieval land, we use virtual consultations all the time, and we've been phoning toxicologists for years now to get virtual consultations and assistance. So virtual consultations aren't actually new. What's new is the technology and the way we're now using it. So how did virtual ED or the Victorian virtual ED start? So this is our reality in Victoria. I'm pretty sure this is your reality everywhere. It's a reality across the world. Yeah, crowded, emergency departments, lots of ramping, multiple patients sitting on trolleys. It's everyone's worst nightmare. So you bring COVID into the picture now and people say to you, hey, can you organize to social distance your waiting room? And we're like, are you crazy? Like, we have 380 patients coming through on an average day. How are we going to socially distance our waiting room? And, as Delta was kind of coming to our shores, we're also sitting there going, hey, a lot of patients that are supposed to be coming to us aren't coming to us because they were really, really scared to come in. And so we started seeing these patients that were coming in with really advanced disease, with perforated appendixes and gangrenous gallbladders coming in. And so we're like, we need to come up with an idea to really reach out to our community and say, we're here to help you. So this kind of really gave us the landscape to think about how could we reimagine healthcare. Yeah, so that COVID was the great enabler of innovation. So what is the Victorian virtual ED? Believe it or not, the Victorian virtual ED was set up originally, it was called virtual triage. It was set up in 10 weeks. It was a whole of hospital collaboration. And what we did is we offered a domain where patients could go to, click on an icon, identify themselves as suitable for the service, register, and this would direct them into a virtual waiting room for a consultation. At the same time, we launched this with various healthcare providers in our community. So GPs in the community and aged care facilities at the first iteration could contact us as well. And so we launched 2 virtual care pathways, and this was back in October 2020. We had our patient pathway where patients registered, put in all the information they needed electronically, and on submission came through to see our virtual triage nurse. Using video technology, they would then triage the nurse as either too sick for us, we need to get you to the hospital, too well for us, you can actually go back to your GP or community provider, or yes, you're actually suitable and we're going to send you to the virtual doctor. We also had our healthcare pathway, which has grown substantially, and I'll take you through that in a moment. But essentially that bypassed the triage nurse because this was a cold consult. The understanding was that the GP or the nurse sitting with the patient had already decided they were suitable for our service. And so they would put in a different QR code or link, put in that information and come straight through to the emergency physician manning the virtual floor. And then we created all these kind of virtual dispositions for patients. So we worked out how to pop them into hospital in the home virtually, how to directly put them into outpatients. I started saying to people, actual ED is not passport control. You do not need a stamp in your passport, your ED passport, to get an outpatient clinic appointment or to get a HIT admission. We've realized through the virtual means that you can actually bypass ED altogether. And so we started thinking about every possible way to bypass the ED. And so Once you came through either pathway, you came through to one of the delightful virtual ED staff, and we can bring in multiple people into a consultation. We can bring in interpreters, we can bring in other specialties, and we can do a 3, 4, 5-way consultation to get that patient sorted out. So how have we travelled since October 2020? So to date, we've seen over 200,000 patients through our service. We currently have about a 70% adult and 30% pediatric ratio. This data was only current just going into the December period. And at that stage, we were seeing just under 600 patients a day. Over December peak, we were seeing up to 900 patients a day. So one of the real benefits of the virtual world is your ability to expand your capacity really, really quickly. We to date are diverting anywhere between 80 to 85% of patients, depending on what stream they come from, and we survey every patient that comes through. We have overwhelmingly positive feedback from all our patients. So where do our patients come from? So at the initial launch, I told you that we had patients coming from the community and we had patients coming from aged care, patients coming from GPs, but actually one of our biggest provider is currently Ambulance Victoria. So towards the end of 2021, we started collaborating with Ambulance and created direct referral pathways and co-designed some of their CPGs. Currently, we see up to about 100 to 130 AV co-consults a day, about 100 of them from infield in the home and about 30 from aged care facilities. And as I mentioned, we divert about 80 to 85% of patients. So that's 85% of AMBO crews that don't need to transport to hospital, ramp with unnecessary patients, and those patients have much better outcomes. We've also done various other external stakeholder engagement, and so we've also partnered with AV Secondary Triage with Ambulance Victoria and recently launched with them. So patients, we call it you've got nowhere to go if you're coming from an aged care facility anymore. You cannot creep through the back door and get into an ED. If you phone 000 and they don't think you're suitable, you come through AV Secondary Triage and you come to VVED. If you call 000 and they do dispatch and AV then think you're suitable, you come through to VVED. If you're an aged care facility and phone us directly, you come through to VVED. So we're trying to keep aged care patients at home is basically the take-home story there. We also now work with Nurse on Call, and so patients that are deemed suitable and would otherwise have been advised to transport by private transport within 2 hours also get diverted to us as well. So we see about 50 to 60 patients that ordinarily would have driven themselves into ED based on Nurse on Call's advice, again hitting 80 to 85% diversion rates in that space. So as I've alluded to, we've done a lot of work in the aged care space. Originally, we just started partnering with a couple of aged care facilities, but as you can see, there's been significant exponential growth, and we can see up to 80 aged care facilities a day, which is very onerous. They're very time-consuming consultations, but well worth our time. Our palliative care arm has grown significantly, so kudos to the speakers earlier. We're also doing, it's amazing work. Being able to keep a patient at home and allowing them to die with dignity is really our goal. So this is kind of bread and butter for what comes across the aged care room on a daily basis. So, 96-year-old from an aged care facility presenting with what appears to be new onset stroke, has an advanced care directive for comfort care. We've spoken to the treatment, the family about what their treatment goals are, and we do shared decision making. So this is why it is so time consuming. We'll then prescribe the medications required to initiate palliative care drugs, and that crew spent 90 minutes on scene, which some people will go, 90 minutes on scene is huge. But if you consider the dignity that gives that patient who's clearly dying and prevents them ramping and dying on a trolley in ED, AV have turned around and said they wholly support us. And we've shown that through the virtual ED and diversion rates, we're saving hundreds of hours of AV time every day, and we've saved millions of dollars. What have we done in the pediatric space? And this is where I feel a bit more comfortable because, as I mentioned yesterday, I'm a pediatric emergency physician. So Susie was meant to do aged care and I was meant to do pediatrics. So now I can go, got through all the aged care stuff in one go. So we've done heaps of work in the pediatric space. And as you can see, we've seen over 60,000 pediatric patients since inception. We have much higher diversion rates. As most of you know who attend patients at home or have them coming to your EDs, a lot of it is worried parents and all they need is reassurance. So that's a lot of what I do on a virtual ED shift is I just speak to families and reassure them about the expected outcomes for their children. We get an overwhelming 95% positive patient experience score, and there's really no doubt why that happens. Who wants to bundle 3 children into a car when you're worried about one of them on a busy night, take them into an ED, sit for 4 hours to be told you need Panadol and Nurofen, you can go home now. You know, we can deliver that virtually. So you can see we've had significant exponential growth in the pediatric space, so much so that we've actually launched a separate pediatric service. We call it Virtual Kids, which is completely staffed separately. So it has pediatricians, pediatric emergency physicians, GPs and nurse practitioners with pediatric experience. So really trying to deliver to the maximum of our scope of practice. And this has many benefits. One is that if you work into your scope of practice, you obviously work quicker, but also we get a lot more engagement from the community. One of the interesting things that I always say about the virtual medium, which is people sometimes forget, is if you think about the rural regional sector, up until this project launched, if you lived in Echuca, for example, your chances of seeing a pediatrician or pediatric emergency physician was basically zilch. Yeah, you got into wait lists where you waited for a year to go and see a doctor down at RCH if you were lucky. Now, they now have access on a 24/7 basis to pediatric expertise, and we can often take patients who've been waiting 8 or 9 months on a waiting list to see a specialist and resolve their issue in a 20-minute phone call or video call. So where do our referrals sources come from? So again, we started off mostly with community referrals, so patients self-referring, but as we've transitioned to engaging nurse on call and AV triage and ambulance, we've flipped a little bit, and again, we've got about a 40% healthcare pathway engagement as well. So again, great stats in the AV secondary triage. We're seeing a couple of patients every day, but really nurse on call is where we have our greatest impact, with 50 patients a day coming through, and again, boasting a 90% diversion rate, and we have followed all these patients up. So there's been no significant incidents or problems with these patients. A lot of people go, oh, well, you're just becoming a GP service. You're just seeing those patients that could have otherwise gone to your GP, and it's a waste of specialist time. So I always like to remind them that there have been some cases where we've actually been a life-saving intervention. We've had several of these cases where this one in particular was an 18-month female, came through with less than 48 hours of fever. GP had seen that morning and said, oh, it's just viral, don't worry about it. Contacted us 6 hours later post the GP consultation, looked septic and shocked over the video, got AV involved, transported to PICU and spent an extended stay in PICU with group A strep sepsis. Subsequent to that, only about 3 weeks later, we had another patient, very similar history, who actually landed up arresting, got into ECMO and had a good outcome. And I'd like to think that timely intervention by seeing a specialist who said, yes, you're sick, yes, you need an ambulance now, really helped to save that patient's life. So again, as I mentioned, one of our biggest impacts is in the rural regional sector. We currently support about 50 urgent care referrals a day, recognising that there's a significant gap in rural regional Victoria at the moment. There are some urgent cares that have no staffing at the moment, where others have significant deficits, particularly in the evenings and on the weekend. And so we help to bridge those gaps. So the nurses will contact us with patients and we will do a co-consultation. We can prescribe, we can do drug shots, we can actually admit some of those patients to our virtual ward and help that nurse look after that patient for several hours while they improve, with the intent to try and prevent unnecessary transport. So we know that the impact of sending an ambulance out of region, particularly in rural regional, is significant. You send an ambulance 2 to 3 hours away to then ram for something that didn't need to go there, that is huge. So the ability to keep those ambulances in their region and stop unnecessary transport is really the goal. Are we safe? So as I mentioned, we've seen over 200,000 patients so far. We've only had one ISR 2, which is RISMAN, no ISR 1s. So I think that's pretty good going if you compare us to other health services. We have set up multiple review processes to try and, based on various RISMANs, identify high-risk groups and manage them. So one of them is our priority population. So we know that our First Nations population have very poor compliance with what we tell them to do. So they now get a follow-up phone call every day to say, hey, did you listen to our advice? That's been life-saving in a few instances. We had a 18-year-old Aboriginal girl who swallowed a whole bunch of button batteries and then didn't attend ED on our request. And the next day we contacted her next of kin and had her transported to hospital. So I'd like to say that was quite a life-saving event. We also look at some of our really high-risk populations, like over 65. So anyone over 65 in community gets a phone call the next day to say, hey, did you manage to get hold of your GP? Did your symptoms change? Do you need to see us again? And then we also have a whole cohort of complex frequent presenters. So we've delightfully got a whole bunch of people who've realized virtual care is better than going to the ED every single day. And so they call us every single day. We've got one particular gentleman who has phoned us 3 times every day since inception of the service. But he used to attend an ED 3 times a day. And so I say to myself, if you look at the cost benefits, he never gets past the nurse in most instances. So he gets a 10-minute social chat with one of the nurses and then discharged to community. Previously, if you looked at his medical history, he used to get an admission to short stay, get bloods, an ECG. It often came by ambulance. So if you think of the cost implications of transitioning him to a friendly chat, it's actually pretty enormous. And you know, we've also worked very closely with a lot of the providers. So we're really lucky in Victoria. We've got a lot of priority care centres that have been set up that have been really helpful. So we work really closely with them. So if patients do need an in-person consultation, we can give them a call and slot them into a same-day appointment. Up until the respiratory clinics lost their funding, they were really helpful for the COVID patients. And then we work really closely with our residential in-reach teams. So these are specialist geriatric teams based at multiple different hospitals. So if we see a patient in aged care, we can often say to AMBOs, give us that dose of antis, and we'll get aged care to come and pick up their care. And so they'll get a geriatrician come and visit them within 24 hours and pick up that patient's care, which has been why we've been able to hit such high diversion rates in aged care. We also are really big on equity. So we have a whole group or working group that sets up our equity. And as I previously mentioned, we do heaps of work with First Nations people. So I guess what I'm hoping to share with you is that we're all in a crisis, and that you could be one of the people that stands there and goes, I'm drowning, I'm drowning, I'm drowning. But this is actually a really great opportunity to think about how to do things differently. I think we're a bit far behind other industries in terms of embracing technology and really seeing how far we can push to make things better for ourselves and for our patients. So really do look to technology to see if you can solve some of your local problems. And we really need to be part of the cultural change and stop being so resistant. We're really stubborn as a medical fraternity. So this is Mercy Hospital in St. Louis in the US. So this entire hospital doesn't have a single patient. It only has virtual care doctors and nurses running it. They run ICUs virtually. So if a nurse in an ICU needs to go on break, they will man the monitors and video that's manning that patient and let that nurse go on break. So this just gives you a little insight into what is actually happening in the rest of the world and what is actually available in virtual care. So I always like to give them South African, end off with the Nelson Mandela quotes. It always seems impossible until it's done. So 2.5 years ago, I was a director of pediatric emergency. I'm now a director of a virtual care program. You know, the world changes and we have that opportunity to change with it. Happy to take any questions.
Any questions for Loren? All right, I think that was a great way to finish up. So let's hear it once again for Loren. Well done. So unfortunately, it's the final sort of part of the formalities of this week. The good news is there is no me talking at the closing party tonight. So it really is just an opportunity just to enjoy yourself and reflect on what has been a great week, both on the slopes and off. One thing that we do like to do each year is donate some money to charities. So thank you to everyone for their attendance, I guess, and registrations. We have been able to donate over $2,000 towards Full Stop Australia. So We'd also like to give another round of applause for all our presenters that came on this week. So thank you to the presenters. Hopefully you all learned something a little bit different. It was a bit of an eye-opener in terms of what else is happening in other sides of Australia, or even sort of for our New Zealanders in the room as well, a bit of an insight to whether it's your own profession or other professions. So thank you, our presenters. And finally, thank you to all of you. So Dylan and I absolutely love doing this. We have to go snowboarding for the majority of the days. It's not too bad. So what we do like to do though is we really want to be able to continue to run these events and continue to improve on them. So tomorrow you will get an email. It has a little survey link on there. If you are able to spend 2 to 3 minutes just to fill that out, please let us know what you like, what you didn't like. If you're running these events, what would you like to see differently? And hopefully we'll see you all here again in a future year. So thanks guys, that's it, and we'll see you all tonight at Pirate Man.